Hello and welcome to my channel. Today's lecture is about the liver, so let's start. The liver, or hepar, averages between 1 and 2.5 kilograms. It occupies the right hypochondrium, the epigastric region, and reaches the left hypochondrium. So it's a large organ occupying a lot of space in the abdomen. It's easily lacerated. If you attended before an operation of liver biopsy, you can so you saw the amount of bleeding just by pinching a sample from the liver tissue. The bleeding was profuse, and it takes time to control it. It's kept in place by the peritoneal arrangement around it, because it's an intraperitoneal structure, plus the intra-abdominal pressure. So it sticks to the back of the abdomen and the sides of the abdomen by the mainly by the peritoneum and the abdominal pressure, of course, that keeps the organs in place. The borders of the liver, the superior, the right, and anterior surfaces are separated by smooth borders. They are not borders, they are surfaces. But for the lower part, you see the inferior sharp border of the liver that separates the posterior inferior surface from the anterior and the right surfaces of the liver. It's very well shown here. This is the inferior border, and it's notched by the ligamentum teres on its way to the back of the liver, and demarcates the beginning of the attachment of the falciform ligament, the one you see here. See, this is the posterior view. This is the fissure for ligamentum teres, and at the front you can see the falciform ligament. Now, the liver normally not palpable except in children. It descends only for 1 centimeter below the costal margin, so that's considered normal. But it's not palpable, shouldn't be palpable, because it's a soft tissue organ. If palpable, there's something wrong in the liver. Okay, these are about the borders and surfaces of the liver. The surface anatomy of the liver, you can start by the fourth right intercostal space mid-clavicular line. It reaches below the nipple, so it's high up, and this is where you should start for percussion of the liver. Going down, start from the fourth space. Going down, you are percussing the liver then. Now, from this point, you can go to the left side, to the left fifth space mid-clavicular line, where this is the point. They call this point the point of 3 APCs: the apex of the liver, the fundus of the stomach, and the apex of the heart. In this point, as we studied in the thorax, the apex of the heart is in the left fifth intercostal space mid-clavicular line. Now, from this point, you can go down, cut the left costal margin around the 8th costal cartilage, and then you go traverse the abdominal wall till you reach approximately a point where the midclavicular line and the transpyloric line meet. This area, this is the tip of the 9th costal cartilage, where the fundus of the gallbladder is, and then you descend for a while till parallel to the costal margin, ascend again on the right side till you reach the right fourth intercostal space. So as you can see, it's a huge organ, and the middle part, it extends hand breadth below the xiphoid process, and the anterior abdominal wall is directly anterior to this part of the liver, so it's liable to injury. This tells you how you proceed when examining the liver by palpation, either from below or percussion from starting from the right fourth intercostal space mid-clavicular line. So these are the borders and of the liver that demarcate the surface anatomy of the liver. The surfaces of the liver, we have the superior surface. It's related to the diaphragm, of course. In the middle, there's the pericardium and the heart. On the right side, there is the right lung base and pleura. On the left side, there is the left lung base and the pleura. So occupies a good area of the inferior surface of the diaphragm. Now, the anterior surface related to 6th to 10th rib on the right side, 7th and 8th costal cartilages on the left side, separated on the right side by pleura and diaphragm, of course, because all this is hidden under the diaphragm. The central area of the liver, hand breadth below the xiphoid process, is related to the anterior abdominal wall. And the right surface, you can divide it into three parts. The upper third is related to the diaphragm, the pleura, and the lung. The middle third is related to the diaphragm and the costodiaphragmatic recess. The lower third is related to the diaphragm and the thoracic cage. So these are important relations of the right surface of the liver, and they always ask about the right relations of the liver in relation to the diaphragm, the pleura, and the lungs. The posterior surface, it's not what you see here, it's only this part. This is the posterior surface. This is the continuous with the superior surface, which is narrow. This is the posterior surface, which is wide at the right side and narrow on the left side, with the caudate lobe extending or showing on the posterior surface and extends into the superior surface. On the right side, as you can see, these are the attachments of the pleurae. This is the right triangular ligament. This is the coronary ligament. So this is a bare area of liver, and it's called the major bare area of liver. Only connective tissue separates it from the diaphragm, and that's why metastasis of hepatoma, for example, spread through the diaphragmatic lymph nodes if they reached this part, the bare area of the liver. On the left side, the caudate lobe, as I told you, is related to the on the left side of the posterior surface. Posterior to it are the cruria of the diaphragm, separating it from the aorta. You can see an H-shaped structure here. On the right side, the fossa for inferior vena cava. Below is the fossa for the gallbladder. The left limb of the H is the fissure for ligamentum venosum up, and the fissure for ligamentum teres below. And in the middle, the transverse stem of the H is the porta hepatis. In the fetal circulation, this is called the fissure for ligamentum venosum, which is a remnant of the ductus venosus. Blood comes through the umbilical vein and opens into the left branch of the portal vein. And from the portal vein, a ductus venosus travels in this fissure and goes anterior to the caudate process, opens into the left hepatic vein, and from the left hepatic vein into the inferior vena cava. So the blood coming from the mother, the oxygenated blood through the umbilical vein, is directly poured into the inferior vena cava. This is the role of the ductus venosus, which collapsed and became the ligamentum venosum, in the fissure for ligamentum venosum that extends deep to the caudate lobe of liver. On this surface there is an impression. See this impression? This is the impression of the esophagus going into the stomach on the posterior-inferior surface we will talk about now. But remember the esophageal impression in this area left to the fissure for ligamentum venosum and the caudate lobe of liver. The inferior surface, all this surface is the inferior surface. See, now you can imagine the exact position of the liver. It's inside in the abdomen. It's tilted so that the inferior surface faces directly down, and this faces posterior and this superior. So only this area is posterior, not all this. Now you can imagine the anatomical position of the liver. The inferior surface is the visceral surface, and it has a bare area at the porta hepatis, the fossa for the gallbladder, and the fissure for ligamentum teres. We studied the esophageal impression on the posterior surface that leads to the gastric impression on the left lobe of liver, the posterior inferior surface of the liver. All this is the gastric impression. Now, this needs some imaginations. Do you see this prominence? This is called the tuber omental. It fits into the lesser curvature of the stomach. When all organs put in the anatomical position, this eminence fits into the concavity of the lesser curvature of the stomach. The touching it is the lesser omentum, and below it, below the lesser omentum, is the pancreas. So the pancreas pushes this area of the lesser omentum against this area of the liver, which is called the tuber omentale. There's also the caudate process of the caudate lobe. See this process that extends to the right lobe, and there's a quadrate lobe bounded on the left side by the fissure for ligamentum teres, on the right side by the fossa for the gallbladder and the gallbladder. This is the quadrate lobe of liver. If you want the organs related to this area, if this is the stomach, so this is the first part of the duodenum on the quadrate lobe. It reaches till the neck of the gallbladder, and then the second part of the duodenum descends related to the body and fundus of the gallbladder, or mainly the neck and body of the gallbladder. So here you will find the descending part of the duodenum. Now, on the right side, there is a big impression here. This is the right renal impression, and the impression for the right colic flexure as it's sticks to the anterior surface of the lower pole of the right kidney. So you have a renal impression, you have a colic impression on the right side related to the quadrate lobe, the first part of duodenum till the neck, and then the second part on the neck and body. And on the left side, you have the gastric impression, the tuber omentale, and the esophageal impression on the posterior surface extending to the superior surface. Okay. Now, this plate, inverted liver, because this is the scene you see in the surgical field. When you elevate the liver, this is how you see the liver from below. And this is how we bring it in exams to examine the students, ask the students about the different impressions. So please study the relations of the liver, especially the posterior inferior surface, upside down. It's upside down to you when you study it, but it's actually exactly what you see in the surgical field. So this is the gastric impression here and the esophageal impression here, and this is the first part of duodenum, second part of duodenum, the transverse colon coming this way to the right colic flexure and the right kidney on the right side. This is why I brought you this plate and inverted it upside down, so as not to get, surprised when you find it in an exam put in this way. Please don't forget to study it in this position. The hepatic lobes. We have 4 lobes in the liver. The right lobe of the liver. We're talking anatomy now. We are not talking physiology. Right lobe of liver, left lobe of liver. The boundary between the right and left lobes are the fissure for ligamentum teres from the back and the falciform ligament at the front. You can see that. This is the right anatomical lobe. This is the left anatomical lobe, and I'll tell you why it's important to know the physiological lobes of the liver. From the back, this is the caudate lobe of the liver, and this is the quadrate lobe of liver. So we have 4 lobes of the liver. You know the boundaries now. The quadrate lobe between the fissure for ligamentum teres and the gallbladder. The caudate lobe between the fissure for ligamentum venosum and the inferior vena cava and its fossa. So this is how you divide the liver anatomically, but it's not the way you deal with the liver in surgery, because in surgery you worry about the blood supply of the organ you are working on. Okay, this is why you study the physiological lobes of liver. Physiological lobes of liver follow one of 3 branches of 3 structures, either the branches of the hepatic artery or the bile duct or the portal vein, not the hepatic veins. And this is a question. You divide the liver into segments according to the branches of the hepatic artery, the hepatic ducts, and the portal vein. Why not the hepatic veins? Because hepatic veins, they drain multi-segments together. They want to collect blood as fast as possible and pour it into the inferior vena cava. That's why it doesn't follow the pattern of the hepatic artery or the bile duct or the portal vein. The hepatic artery divides at the porta hepatis in a V-shaped manner. The portal vein divides in a T-shaped manner. It gives a right branch and a left branch, as you can see here. The left branch gives a lateral branch and a medial branch. Each branch divides into superior and inferior, or upper and lower. The right branch divides because the mass of the liver is bigger at this side, so it divides, instead of lateral and medial, into anterior and posterior branches. And each branch subdivides into superior and inferior, and by telling you the branches of the hepatic artery, actually I'm telling you about the segments of the liver. Okay? Now, in this pattern of supply, the medial branch of the left lobe of liver, the medial of the left hepatic artery, I mean, supplies the caudate and the quadrate lobes. Supplies the caudate and quadrate lobes. So physiologically, it belongs to the left side. Now, if you have a look on the liver, again, anatomically, the quadrate lobe and the caudate lobe at the back belong to the right anatomical lobe. So now you understand it. The caudate and quadrate belong to the right anatomical lobe of liver, but belong to the left physiological lobe of liver. Please understand this. This is important because this is as I told you, what you follow in if you are doing a partial hepatectomy, for example. See, this is a drawing to show you the segmentation of the liver, named after the branches of the artery: anterior superior, anterior inferior, posterior superior, posterior inferior. The caudate, which is medial superior, medial inferior, therefore the quadrate. Lateral superior, lateral inferior segments. See, here the right lobe of liver, they mean the anatomical lobe of liver, see, demarcated by the falciform ligament. But the right part of liver, as they name it here, or the right physiological lobe, follows the branches of the hepatic artery. But how to plot this on the anterior surface of the liver? By drawing a line, imaginary line, between the inferior vena cava at the top and the fundus of gallbladder at the bottom. This demarcates the right physiological lobe from the left physiological lobe. So please understand these points. What demarcates the right from left physiological lobes? An imaginary line passing through the inferior vena cava at the top and the gallbladder, fundus of gallbladder at the bottom. See, the quadrate lobes and caudate lobe belong to the left side now, but if the demarcation or the boundary between the right and left anatomical lobes is actually the falciform ligament at the front and the fissure for ligamentum teres at the back. This is what demarcates the anatomical lobes. So the physiological lobes are more important than the anatomical lobes, because these are the clinically important segments of the liver. Now, for the peritoneum of the liver, the liver invaginated the top of the closed peritoneal bag. Remember the closed peritoneal bag we talked about when describing the peritoneum of the abdomen. The organ invaginated the top of the bag, but it wasn't completely engulfed. It is an intraperitoneal organ, but not completely engulfed. And the proof here, because it has a superior or a bare area, major bare area, as you can see here. Now, if you're asked about the bare areas of the liver, this is the major bare area, lies between the anterior limb and posterior limb of the coronary ligament together, that meet on the right side at the right triangular ligament. This is the right triangular ligament. And this is the left triangular ligament, one of the peritoneal ligaments of the liver. We'll continue talking about the bare areas. Now, if you remove the inferior vena cava, its fossa is a bare area. If you remove the gallbladder, the peritoneum covers the back of the gallbladder here. But if you remove the gallbladder, the fossa for the gallbladder is another bare area of the liver. Now, the peritoneum reflects C around the porta hepatis. So the porta hepatis itself, which is described as a deep fissure of the liver, is a bare area of the liver. See? And same applies for the fissure of for ligamentum teres. The fissure itself is bare because the peritoneum is reflected. And as you can see here, the fissure for ligamentum venosum, the two layers of peritoneum are reflected. So this thin line between the reflection, site of reflection of peritoneum, is another bare area. And at the front, the base of the falciform ligament is another thin bare area of the liver. The base of the left triangular ligament is a bare area of the liver. For the ligaments of the liver, don't forget the falciform ligament at the front, the ligamentum teres, the ligamentum venosum, the left triangular ligament of liver, the right triangular ligament of liver, and the coronary ligament that consists of the anterior limb, posterior limb that meet in the right triangular ligament of the liver. Okay, we covered this part of the liver in this lecture. I hope you got the maximum benefit from this lecture, and thank you very much for watching.